Good evening. I'd like to welcome everyone to the June meeting of the Pitt County Board of Health. We'll start out with a roll call, please.
Tom Colson,
Here.
Tina Dixon,
Here.
Martha Engelke,
Here.
Rex Fleming,
Here.
Adam Harrell,
Here.
Mark Hayes,
Here.
Scott McIntosh,
Here.
Kelly Pack Smith,
Present.
Lowell Spate.
Here.
We have quorum.
All right, very good. Thank you, Betsy. We start out after the roll call with our public comments. We're pleased to have from Vidant, Mr. Brian Floyd, President of Vidant Medical Center, and Dr. Nidhi Armistead, Chief Medical Officer, who are going to do a presentation.
Thank you, Mr. Chair. Thank you for having us here. We're pleased to be here and partner with you as we're all addressing the significant challenges associated with the coronavirus and the work that we're doing. We thought it would be appropriate for us to come together just to let you know what's going on from the perspective that Vidant has here in Pitt County. And I'm glad to be here with my partner who has leading a wonderful team of people to help partner together and prepare us for the response to COVID-19. And just a quick reminder about mission, vision, values. This hospital, Pitt County Memorial Hospital, Vidant Medical Center, and our health system exists to improve the health and well-being of Eastern North Carolina. I say that only because I want to remind us that the hospital belongs to this area. It's fully committed and dedicated to the same thing it was years ago as Pitt County Memorial Hospital, and to the same thing that this board is challenged with in dealing with the health and well-being of Pitt County. Over the years, it has grown. It obviously now is one of the nation's largest hospitals, but I want to remind us that it belongs to this county. It is still a fundamental part of the health and well-being of the citizens of Pitt County. And so when we build that apparatus to do the work of providing care, we're doing it really and truly with a focus. How do we bring resources to Pitt County and to the citizens of Eastern North Carolina so that we can help partner with others to care for them? And the coronavirus has brought with it significant challenges, and we have therefore had to make significant adaptations and investments into how we respond, how we restore the community, and then how do we reimagine the work for the future as we partner with others to care for patients and the people we serve beyond coronavirus. So one of the things we want to start with is this response. We like to break down the work we're doing in the system in terms of this respond, restore, and then reimagine. The response, you might recall, we came and talked about at the very beginning of this, and Dr. Ramsey, you have been fundamental in helping us understand internally COVID-19 and what needs to be done, and we're appreciative of your work heading up infection control in our hospital. And obviously, Dr. Silvernail has been a wonderful partner, and the board should know that we really appreciate working together for Pitt County to figure out the very first problem of how do we flatten this curve? And you might remember the worry we all had that if we weren't aggressive and we didn't have our community and citizens come together and practice disciplines and learn together how to respond, we could be in real trouble. And I'm pleased to say, as I know you are, that while we have a ways to go and while we are seeing the curve flatter than initially the projections were, we have to thank the citizens who have helped us. And Dr. Armistead is going to share a little bit more about how we continue forward, what got us where it is, and then how do we make sure we don't regress back to a situation where the initial curve was still the most important and pressing issue. How we responded initially was to make sure the system is operating as one and is adaptable to the changes needed for addressing coronavirus. We had to decrease the volume and complexity in the county's hospital to make room for an unknown surge of patients. Obviously, that dealt with changes to our scheduling system, surgeries and elective cases and things of that nature. And so we were able to do that. The next thing we had to do is build the testing and logistics to be able to care for the COVID-19 virus itself. And we're going to talk a little bit about what that means specifically, but we have made significant investments in our ability to test for COVID-19. And today, more than $5 million have been invested into this county's hospital in our ability to return a result for COVID-19. And obviously, we're partnered with the county to make sure we're doing the right thing. I say that largely because this capability that you're going to hear about is profound for the people of the East and for the people of this county. And we would like to partner together to make sure we can do the testing with the county to result those results within 24 hours. And we have the testing capability now. And so one of our asks would be that this board endorse the partnership with us to make sure we can test instead of having the dollars and the work go to another agency outside of Pitt County. We'd like to keep that work local and use the investments we've made here to help fuel the engine further at your hospital here from a testing perspective. We had a lot of discussions early on about the critical supply needs, and you remember worrying about how we were going to handle PPE. I'm so pleased that the partners who came together here in Eastern North Carolina, ECU, and many other businesses to make sure we had durable supplies, and we're in good shape from a PPE perspective. Building data and information systems became a huge task, and Dr. Armistead is going to review what that means, where we are with that so that it can be understood. And then obviously communication and taking care of our people, really quick responses. The system totally has spent about $23 million investing in our response to COVID. And again, I say that because of all the things that we have had to do. 66% of that really is Pitt Memorial Hospital, Vidant Medical Center investment into the core here. And now we'd like to talk about how we can use those investments. And obviously, the more we do here in our own hospital, it keeps that local. It also helps support our investments and return those dollars back into the county here, which supports this community. I'll remind us that Vidant is obviously huge in terms of delivering care in the region, but it's also a very large employer. It's very much a part of the economic stimulus here in Pitt County. And I believe we ought to use all the resources we can locally to help keep that stimulus going, because part of the next phase beyond respond is recovery, and recovery is going to take all of us maximizing the local investments we can make to help make sure we can help this community recover beyond the illness itself in all the other ways that means. So I'm going to ask Dr. Armistead now to walk through some of the results that we have been seeing with COVID-19.
Thank you, Brian, and thank you also to Mr. Chairman and to the esteemed board for this opportunity. So like Brian said, initially it was all about responding and averting a crisis. And thanks to the good leadership from this group, we're so fortunate that we were able to be successful in that. So over the next few minutes, what I hope to do is just kind of walk us through where we currently are. What tools have we built using the Vidant Health machinery that we then will use as the foundation of where we go from here in terms of facing this all together. So this graph illustrates the case count on a daily basis. You well know this number. And over time, some of us will remember some number of memory, and some days it's high and some days it's low. And of course, it was a very, very active latter part of the week here with the outbreak at one of our skilled facilities. A graph that's a little bit more stabilizing from the day-to-day fluctuation is looking at a 3-day average or a 7-day average. And what we're learning about COVID is it is a up and down kind of a story. But the overall trajectory of that graph certainly does seem to be worrisome still. It is not a downward going trend for sure. It continues to go up. And will we, who knows where we will go, but the current numbers there because of the weekend that we had certainly are a very sobering reminder that COVID is very much amongst us. This sort of allows me the opportunity to switch to the tools and capabilities that I'm so proud of, to be a part of a team that immersed in the innovation and did it in an accelerated manner. And just amazing collaboration with our partners at ECU, Brody School of Medicine, as well as, of course, the leadership from the folks in this room. This is a table that is familiar to Dr. Ramsey. We look at it on a daily basis. And what it allows us to do is each day, just wake up each morning and see what the activity is. So as of yesterday, we woke up to a number of in-house patients that's on the higher end that we've seen. And we know with COVID, the hospitalization is a lagging indicator. So the case count that we saw, that 50 number that we saw a couple of days ago, is probably not the reason for that 73. So we can fully expect that 73 number to be a good bit higher a week or two from now. So this just allows us to remember each day that COVID is very much amongst us and allows us to then meter the rest of our activity that we still need to perform and serve while we continue to be prepared to deal with the needs of the COVID patients. It also is very heartening to see that there are lots of people who get better and go home. So over 350 patients have been discharged. Of course, it takes a toll on the death count as well. So sobering numbers, encouraging numbers, reality check, all sort of in a one single snapshot. We look at our testing capabilities that Brian referred to, and each day we can see the activity of the day prior. You see that number 55, woke up Saturday morning. It's like, whoa, that was a busy day. In the same week, we had our highest number of tests at the medical center. Altogether, we did 563 tests in a single day. And in the same week, on a different day, we had the highest number of positive resulted tests on this. So we're able to splice and dice the data in all different ways and look at trending. The second graph there shows us back to that percent positive number, and that the fact that it was coming down was encouraging. And then over the last week, you can see that orange line uptick again. All of this allows us to just know what's going on and make decisions that are driven off data. So the testing capability that Brian was referencing earlier is something that I am so grateful that I've learned through this lesson that the healthcare heroes come in all different forms. Of course, our nurses and doctors who are at the front lines, putting their life on line sometimes to care for patients, are heroes, but so are behind the scenes folks, the folks in infection control, who keep us safe behind the scenes. And same also with folks in information systems and laboratory services. They don't often get the limelight they deserve, but in moments like this, they really have risen to the challenge for us. We know that testing has been a challenge nationally, internationally. So we are so fortunate that in Eastern North Carolina, based on several different instruments and reagent types, we have now built sort of a Swiss cheese model where we have redundant layers, where if one breaks down because of a supply chain issue, thank goodness we have a backup plan and a second backup plan. So we've not had to halt testing on a given day, even though we've had severe limitations with given reagents. At this time, we are able to process 500 to 750 tests a day comfortably, like you just saw the number from just this past week. By the end of the month, we're looking to increase that number significantly. Coming July, we hope that we would really be able to leverage this capability to do what we need to do, which is just to give things terms so we can think around this. We've called this project Eastern North Carolina Testing Initiative. And this just allows us to think through what is the best way, now that we have built this capacity, what is the best way to use it as a tool in a wise way, not just first come, first serve, not just set a tent somewhere and people get into this 5 mile long line and people just come randomly. We don't believe that's probably the best use of this capability. So our motto has been, we strive to create the safest environment where we work, live, and play, and how can testing be a part of that? As we started to think about it, that's when we really came to the realization, even though this testing capacity seems like an ECU Vidant initiative, in reality, it has to serve the community, and community pieces have to come together. So for example, we know that folks in a congregate living facility are at highest risk of harm and spread. just like what we experienced. So how do we take this testing capacity and our systemness to be able to anticipate and meet those needs? So this framework just allows us to kind of think through systematically what is the areas that need this, and then it allows us to imagine how we can come together in sort of a, not in an org chart structured way, but almost as a coalition of sorts. And that was the group that met about a week ago. The state, university, local health departments, faith-based, local businesses, all components of the community, moving in sort of a systematic way to use this capacity to improve the health of the community. Our testing journey, again, this is a table that Dr. Ramsey has been instrumental in helping us lead as we built our capacity. We had to think about which groups we could offer the testing to. So first would be, of course, very sick patients. Beyond that, to patients with the highest risk. And now we are going into the area of screening and surveillance, but not sort of in a random way, looking at healthcare workers, all incoming patients, congregate living setting, and so on. So trying to approach this in a systematic way, as also is the new capabilities around serology testing. So there's new data coming out about how serology can complement your PCR testing abilities. And we have 2 serology instruments that are very, very high performing tests that can also inform us with surveillance and what the disease is doing in our community. So all that, kind of where we are, we know that COVID is amongst us, and what our, what the capabilities are that with partnership with Brody School of Medicine that we've been able to pull together sort of brings us to this sobering moment about, how do we now use all this to keep our community safe? There is just no debate about what needs to happen. The question is how to make it happen. Biden's position is that we want there to be safe reopening and businesses want the exact same thing. The question is what guidance and support is needed to make those decisions. I would advocate for, universal masking when social distancing is not able to be done. That is not a controversial topic to undertake. CDC and NCDHSS have the exact same recommendations. We know what's the right thing to do, and we can certainly model it. The question is, how do you impact human behavior in a way that it happens, so it becomes an expectation? We know that just telling folks or educating sometimes doesn't always work. So how do we set public policy around this? We know that Dr. Waldron, when he made a presentation to the commissioners last week, made a recommendation that they support an ordinance around universal masking. So a board like this making a similar recommendation really could put us, make a stand and provide some guidance to our businesses for setting this expectation, because we know otherwise the adoption is very, very patchy. That may be the most important intervention that we can do to help improve the outcome, because waiting until they get into the hospital may not be the best way to intervene. You want to intervene sooner rather than later. The other place where I really see the big opportunity for our partnership is around testing, tracing, and tracking. We know that the resources to do all those components are very fragmented, and different parts of our community are charged with different components of it. And if we do it separately, it will not, we need to make 1 + 1 + 1 come to 10, not 2.5, which is what would happen if we work in different directions. So this pandemic is allowing us the opportunity to really just think about how we can make sure that we move in step. And if we're doing a home monitoring system, perhaps there's an opportunity to start partnering with our local health department resources, even as we wait for state help to arrive on that front. So those were sort of the 2 sort of big areas that we can easily imagine us coming together. And then I'm sure there are more. What we look forward to really is right now we're in the restore phase, and how do we reimagine a future that is not looking to return to the good old days, but perhaps in a whole different way, serve this community together. So, Brian.
So I understand that your meeting now, you're going to be talking about a plan and looking at how did we help our community, get where it needs to go. And I would only ask, as Dr. Armistead said, you really take into account, we want to be your partner in that. And we've, what we believe, invested this community's resources in the capability to do that.
Right.
But it's not, there's not much to that unless we're able to do those tests. And so we're asking for your support, your guidance, and your willingness to let us be a testing site for the county's work as that makes sense. And we're certainly willing to entertain a mechanism with which to do that, and would like this board's support in that. So thank you for letting us be here. I want to thank you again for being public and pushing for the health of our community. We're all very grateful for how people have really come together to do the right thing for the community. And with that, we'll just take questions if you have any about it.
Yeah, don't run off now. Let's see if any of the board members have any questions. Maybe Betsy can help me with the monitor here. So. They must be thinking.
They're thinking.
Yeah.
So yeah, Brian, I thought you guys had more resource issues than you do. Apparently, we're happy to entertain a discussion with your lab, as we said last week in our collaborative meeting, whether that's COVID testing or other lab testing that we need to do, where if we can get a better, quicker service through the hospital, we're happy to entertain that.
Yeah, that would be
And use that
incredibly helpful.
capacity.
And it allows us to keep the local resources people are investing in that.
Right.
It brings those dollars back into our environment because it's helping offset the costs locally here, which, as you all know, we need
Yeah.
to support it.
Sure.
And
Yeah.
in terms of the timeliness, I think that's the other key, right? We are getting to the point where our slow test will have a 12-hour turnaround.
Mhm.
Right now, we're not quite there yet because of we're still building the capacity. So it's at 23, 22 to 24 hours, depending on a really busy day. But that is still faster than what it would take to transport a specimen someplace, wait for the results, have the results back. And when we know that as we get more heavy into contact tracing, time matters.
Mhm.
The sooner you can identify those who've been exposed and do the testing and get those results, the sooner you can cut the chain of transmission. So for a condition like this, I think this local connection and the ability to be able to turn around results in a fourth, a fifth of the time, it could really also make a big difference in the disease prevalence.
Yeah. Outside of the Vidant testing, we're seeing turnaround times anywhere from 2 to 10 days. So 10 days on a COVID test, contact tracing is almost meaningless at the point we get a 10-day result.
That's crazy, yeah.
Let's see, we have a couple questions here. First, Commissioner Carlson.
What's the suggested cost or projected cost that Vidant would charge for a test?
Well, I think that obviously that's a negotiation we have to enter into. We're not trying to sell a service to a high bidder kind of thing. What we want to be able to use the service we've built. And so it'll be based on, rates for Medicare and other things that we set the pricing at. But it'll be competitive with any other pricing you're going to get. And when you consider the fact that all the dollars that stay here offset the cost of us building the capability, which help the hospital do well, and when the hospital does well, the community does better. And so it has exponential value, I think, but we will make it, it'll be a competitive price for the county.
Yes, sure. I think.
Can you throw dart at the board?
The county's cost today, do you know what it is at this point where you're paying now?
For most of our testing, right now we send to the state lab, which is free. So I know you can't do that, obviously. In the community testing program that we're preparing to stand up when the CARES funds are available, we're looking at a cost of about $51.30.
Around 50
commercial lab.
was the number that we have heard is out there. It will be set based on Medicare pricing. We won't just make up a cost for that. It'll be set on the cost based on Medicare. And that way it's universally applied through our, payer sources as well as Medicare, Medicaid and the like.
Right. Yeah. All right. Very good. Let's see. I see Martha Engelke has a question.
Yeah, my question was just, if Biden does the testing, will it be community-based or will it be at Vidant Labs?
So that's a really great question. The test itself is run in the Vidant Lab. We actually will have 2 platforms that are available in other counties as well, but at the medical center, there's actually 4 different platforms that will be available. The collection can be done anywhere. So this over the weekend at the skill facility, we were able to work with the staff there, train the staff there, and they were able to actually collect the specimens and then bring them to our lab. We can also do, a swarm activity where if there is an outbreak at a local employer, we can certainly take a mobile unit there and you can create labels, and on site, you can basically do the specimen collection. What we are not looking to do is just prop up community testing for citizens at large who are curious and without necessarily the risk or the exposure or a highest best use kind of a indication for it. What we're looking to do is partner with our local agencies to determine how to best use it. So whether it is doing proactive screening at congregate living facilities or when there's an outbreak situation. So those are all things that we have a pretty good system around, all set up, including with EHR and ability to label on site and bring them electronically. It's all very automated, and it can be flipped depending on where the needs are.
Okay, any other questions from the board members? Mr. Floyd and Dr. Armstead, thank you very much for your presentation. I'm sure that our audience on cable are happy to hear the update about all the activities going on. So thank you again.
Thank you for the opportunity.
Okay, we'll move on to the minutes of the May meeting. Those have been circulated. And are there any corrections or additions to those minutes? Okay, hearing none, we'll need to have a roll call. Let's see, we'll need a motion first to approve. Sorry. Is everybody muted or?
Motion to approve.
Okay. All right. Is there a second?
Second.
Okay. All right. We'll need to have a roll call then for the vote. So
I just need to identify who made the first motion. Please say
I
your name.
did. Tom Colson.
Thank you. Tina Dixon,
Yay.
Martha Engelke,
Yay.
Rex Fleming,
Yay.
Adam Harrell,
Yay.
Mark Hayes,
Yay.
Scott McIntosh,
Yay.
Kelly Pack Smith,
Yay.
Lowell Spate.
Yay.
Thank you.
all right, the amendments are approved. We'll move on to fiscal report. Marcia Hall is here. Here we go.
Hey, how's everybody tonight? We are in period 11, which is ending May, which is also the end of our state funding cycle, which makes it very interesting since our new county budget starts July 1. Our overall budget is $12,014,906. And if you look over across to with our timing items, we do have quite a big surplus, which I went back and double checked everything. And I wanted I asked myself why such a surplus at such a time. So I wanted to go back and review a couple of things. This fiscal year with Medicaid, we keep in mind that we decreased our Medicaid projections because of Medicaid reform, which at this time sounds like an idea that is long ago. And that was at least 20% against all of our clinic programs. Well, our clinics programs up until COVID was doing really well, and we have surpassed that, all of our projections. We've actually brought in more than was budgeted. And then we also received our Medicaid cost study from 2017, 2018 year, which was much more than we anticipated. And then we also received the 10% hold from the 2 years prior to that this fiscal year. Environmental health, I'm not sure if you recall, but we decreased the projection for revenue for environmental health this fiscal year because they didn't reach that. Well, they have above and beyond this year. I guess maybe the weather and the production and the growth of construction. And we also received all of our county appropriations in May. So overall, May looks really good in taking consideration our time and items. The other category, just want to point out, the other category looks like a larger negative. We did project some items like for the maternity fair, some third-party revenue that during the budget process, we put these things into, well, we expected them, but now with like maternity fair has been canceled with COVID. I'm going to reduce some of that budget this month, so that number will come down. But we just did not receive some of the third-party revenue sponsorships, so I will decrease that. And we have some invoicing for our child care consultant program and our child health program that's not also been received. But does anybody have any questions?
All right, so this is an action item we need to approve,
Yes, sir.
right?
Yes, sir.
Yeah, more than this, or?
I do have some more stuff. I just wanted to, but I didn't know if you wanted to vote on the fiscal report first, but I'm happy to keep going if you'd like.
All right. Does anybody have any questions about the report to this point? So we need to, we need to go ahead and make a motion to approve this. So
I move for approval.
Second it.
okay, we've had a motion and a second, so we'll have a roll call vote.
Tom Colson,
Yes.
Tina Dixon,
Yes.
and confirm that was Martha who made the first motion, please.
Yes.
And Rex made the second motion, please.
Yes.
Adam Harrell,
Yay.
Mark Hayes,
Yay.
Scott McIntosh,
Yay.
Kelly Pack Smith,
Yes.
Lowell Spade.
Yes.
Thank you.
All right, very good. Thank you. And let's see what else you have for
Got a
us.
few more little things. Dentrix, our dental software that we were kind of pushed to buy since HIS is breaking, was purchased in May. We have our first virtual kickoff tomorrow with that company, and we will be going over the schedule for implementation. Hopefully they will be on site and with no hiccups with COVID. We will have that installed and ready to roll when Pitt County schools open. Hopefully before that, we'll be able to practice while the Smile Safari is at health department. We're gearing to make sure that hopefully is in place when schools open up in August. And I wanted to bring up our vacant positions. We have current 19 vacant positions. 3 nursing positions were actually recent to the county office, with one of those being a recent retirement. We will be asking Scott to release those so we can advertise. We did just hire a lab technician that Scott allowed to be approved, and our environmental health director position was released and will close on this Friday. Scott, the county manager, released that. 3 of the positions have been sent to the state to be reclassed, and we have not heard back. Just wanted to give you a follow-up on that. And Dr. Silvernail presented our budget to the county commissioners on June 2nd. And with that, at the time, the county manager had recommended one of our postpartum nurse positions and not the physician extender position. But hopefully with some more discussion, that will be, I'll have a better update for you next meeting.
Okay. Very good. Does anybody have any questions for Marcia? Looks like Kelly Pack Smith has a question.
Okay.
Yes, Marcia, the report about your vacancies, is that relevant to the financial report? That was sent out?
It was not, and I actually meant to, but I was missing the deadline for you to review it, and I was gonna send it out today, but I'm happy to send that out to everybody. If you'd like to give you the status of where all the positions are.
That would be great. Thank you.
You absolutely, we'll do that first thing in the morning.
All right. All right. Looks like Dr. Harrell has a question.
Okay.
I was just going to mention about the Dentrix. I use that in my office. So if I can help Dr. Benson and her auxiliaries in coming along with that, just let me know. I can get together with them.
That sounds great. That sounds really
Yeah.
great. I've offered up my children for test patients too, to take pictures if they need it.
We appreciate the offer.
Absolutely. Thank you.
All right. Any other questions? Well, thank you very much, Marcia. Appreciate
Absolutely.
it.
Thank you.
We'll move on to old business, and we don't seem to, Dr. Silvernail, we don't have anything under old business.
Do not believe so.
Not tonight. So, okay. Move on to new business, the Child Fatality Prevention Team Report, Jennifer Hardy.
Good evening.
Good evening.
This is the 2019 report for the Child Fatality Prevention Team. Even though it is the 2019 report, the deaths that we'll talk about actually occurred in 2018. And I do apologize for it being a little bit late this year because of COVID. We've had to kind of postpone a lot of our meetings. Just for an introduction, the North Carolina Child Fatality System was established by legislative decree in 1991. The North Carolina Child Fatality Task Force was also established in 1991. And then the North Carolina Child Fatality Prevention Team, or the state team, was established in 1992. The local child fatality teams were established in 1993, and there is one per county, so 100 teams for 100 counties in North Carolina. The purpose of the State Child Fatality Prevention Team is to promote understanding of the causes of child deaths, to identify deficiencies in the service delivery to children and families by public agencies, to assess, recommend, and implement systems for change that will prevent future child deaths, and to support safe and healthy development of our children. And then the Child Fatality Prevention Team includes appointed representatives of public agencies, non-public agencies, and also the community. For the local Child Fatality Prevention Team, the chair is Dr. Silvernail, our health director. I do co-chair that for him. And then we have a review coordinator, Portia Mizell, who is fabulous, and we could not operate well without her. The team members include the DSS director or a representative, a DSS staff member, DSS board member, law enforcement office, district attorney's office, community action agency, schools, mental health, guardian ad litem, healthcare provider, health director or representative, EMS or firefighter, district court judge, medical examiner's office, child care or Head Start, parent, and then other members appointed by the county commissioners. For the local child fatality team, we do meet quarterly, and then the subcommittee meets quarterly as well. Just the subcommittee does meet the month before to decide which cases are going to be reviewed. So if we meet in January with the subcommittee, then we decide which cases will be reviewed for February. Child Fatality Prevention Team has statutory access to records of birth and death certificates, medical facilities, the Department of Social Services, courts, law enforcement agencies, the school system, and then outcomes of services and circumstances surrounding the child's death. The main goal of the CFPT is to review child deaths and study ways to prevent child fatalities. And then the other purposes are to identify deficiencies in the delivery of services to children and families by public agencies, make and carry out recommendations for changes that may prevent future child deaths, to promote understanding of the causes of child deaths, and then also to advocate for our children. So in 2018, there were 18 child deaths. And then the Child Fatality Prevention Team, the local team, did choose to review one of those cases. The reason there was one is the majority of the cases did, they were related to prematurity or birth defects. And so they decided to not review those. There were no system problems identified, no existing policies, rules, or gaps in service that contribute to child deaths. That's all I have. If you have any questions?
Very good. Do any of the board members have questions for Jennifer?
Yes.
Looks like Kelly Pack Smith.
Thank you for your presentation. Really quickly, you noted on your last slide that premature deaths were not investigated under this program. Are those covered somewhere else where we're tracking and trending that? I presume so. Do you know
Well,
where that is?
We do track those, but we just chose not to review them for like system issues.
Got you. And so the wholity of that number of premature deaths in our county, is that being monitored and investigated somewhere else then? Maybe
Yeah.
not to the level that you're doing under this program, but looking at demographics, looking at commonalities that are leading to premature deaths?
Yes, we have PIMPAC, which is the Pitt Infant Mortality Prevention Advisory Council.
Yes.
And it's been around for almost 30 years. And so that is the main goal that we have with PIMPAC, is making sure babies get to their first birthday. So we do look at the deaths, the trends. We even look at the zip codes and the codes of causes of death.
Okay, thank you. Yep, I do remember that. Thank you so much.
Mhm.
All right, very good. Any other questions? Well, thank you for a very important report. This is one of our goals, our three main goals last year. One was related to infant and child mortality. So thanks very much for the work y'all are doing.
Thank you.
All right, it said action here. Do we have to approve that report, or?
I believe you do.
We do?
Yes.
Okay, all right. Is there a motion to approve the report as presented by Jennifer? Looks like we have three folks.
Motion to approve. This is Kelly.
Kelly, okay. Is there a second?
So move.
I think that was Rex. There we go. All right, any further discussion? We'll have a roll call vote then. Betsy?
Tom Colson,
Yes.
Tina Dixon,
Yes.
Martha Engelke,
Yes.
Adam Harrell,
Yay.
Mark Hayes, we didn't hear you, sir. Mark Hayes,
Did he say yes?
Yeah.
Yeah, okay.
I wonder if he's muted.
okay,
Yeah, he might be able to hear.
and Lowell Spate.
Okay, all right. All right, very good. Then the report is passed. All right, we'll move on. These next two items, I'm going to sort of take a chairman's prerogative and put these two together because they sort of overlap with each other. One is that we generally do not have a July meeting unless we feel like there's a burning need to. We're certainly obliged to have one, but we have passed on a number of July meetings. But we do have an important evaluation of Dr. Silvernail. He was hired last July 1st, and so his first annual eval is coming up. And so we do need to do that evaluation in July. So I guess we got a couple of options. One is to go ahead and have a formal meeting and then discuss his evaluation in closed setting as we used to do with Dr. Morrow. Or secondly, we could have a shorter call meeting and discuss his evaluation. So does anybody have any thoughts either way? Kelly and Adam and Dr. Harrell. Yeah.
I have used all my words tonight, it seems. Okay, so if we've got as much going on as we do with just with the COVID operations, do we need to just plan to have that July meeting and, like you said, go into a quick closed session to do the eval? Or were you proposing not having a regular July meeting and instead just having a short eval meeting? Is that what you were asking?
Yes, so that's what I was suggesting as as sort of a plan B or alternative, is that we could have a a short conference call, WebEx, and to discuss, primarily to discuss his eval as an alternative. So I don't vote unless there's a tie, so we're open to consensus here. Dr. Harrell?
My first inclination is, if we have to make a decision tonight, I would say we do need to have a meeting based on COVID and see how it tracks over the next 4 weeks. Because that may be information that we need to get out to the public.
All right. Does anybody have any strong feelings on the other direction, or? I see Martha Engelke has a question.
Well, I agree with Adam, and I guess because this time is the time we generally are available, rather than trying to do it at another time, it might be best just to have a brief meeting, at this time.
Okay. All right.
We have to meet to do the evaluation, right? We can't just do it by email.
Exactly. Yes, that's correct. Well, sound like we got, we haven't made a motion, but we got three strong yays and no opposition so far. So I think with that, let's just go ahead and plan on having a meeting.
Okay.
And all right. Let's see. The next is the health director's report. Dr. Silvernail.
Thank you, Dr. Ramsey. First, wanted to share some good news with you all. All of the potentially COVID-19 potentially exposed staff at Pitt County Health Department have returned to work. All of their tests were negative. We did retest the source patient as well. We had some questions about the validity of her first test. And on the retest done through the State Lab of Public Health, her test returned negative. I believe her original test to be a false positive or to have been erroneously reported. There were some date inconsistencies in the lab report, but given that we had a positive test result in our hand, we felt the need to take appropriate action based on that that test at the time. So all of our staff are back at work, and none of them tested positive, and we are pleased to report that tonight. I want to remind you, our Deputy Director, Amy, sitting in the audience here tonight. Amy continues to see the operation of the Pitt County COVID-19 hotlines, and we are seeing 20 to maybe a little over 20 calls a day on those. It sort of varies with what's been in the news, what's happened. I said to Dr. Ramsey earlier today, I think we had about 3 conversations before the meeting today, that this thing is like the Hydra. You cut off one head and 2 grow back. Every time we think we've got a little bit of breathing room, something else seems to creep back up and surprise us. Amy also answers questions from our website. She's helping me with the media management. We have stopped our standing press conference here, a formal press conference, but we are providing a weekly media availability on Wednesday afternoons at the Ag Center on the Pitt County Government Campus. We are meeting with the media on a regular basis. I'm going to jump in and talk about COVID-19. Our cases are up. This is largely due to 2 separate long-term care facility outbreaks. We have one facility where 6 individuals tested positive, but they were all asymptomatic. So again, we kind of scratch our heads when we call this an outbreak because nobody's sick at that facility at this time. In order to be cleared, they need to pass through 2 incubation cycles or 28 days to declare that outbreak over. So we are not near declaring that one over. The other outbreak was larger. At this point, we've identified 42 individuals at that outbreak. 9 of those are staff, 33 of those are patients. 4 of those patients are hospitalized. The other patients remain at the facility, and to our knowledge, as a close of business today, we're still asymptomatic. As of yesterday, the other thing in terms of our county testing numbers being up, we are testing more across the county. When this started, we had a very narrow definition of who could be tested. And over time, that has progressively become wider and wider as to who could be tested. So when you test more, you find more. And that explains some of our numbers creep. Now, can you just pull those up, Amy, the graphs for me? And I'll show you our data. I wasn't going to do that, but I think I will show you our graphs just so that you can see our data graphs. We have, I'm going to mention while Amy's pulling those graphs up, we have stopped reporting a percent positivity in our county data because we do not receive all of the negative tests. This went back to a change in the state required reporting for us, which made it harder, if not impossible, to get all the negatives. We know that we were getting about 100 negatives a day from our largest testing partner, if not more than 100 negatives a day. So at close of business today, we could account for 3,269 total people being tested, 403 positive tests, 282,866, sorry, I can't say my numbers tonight, negative tests. And if I calculated the positivity rate on that with the raw data, it was 12.3%. We think that overestimates the true positivity rate in the county. If I correct that number, adding 100 cases per day for 24 days that we've now not received negatives, that takes the percent positivity rate down to 7.1%, which is consistent with where we were before that data change made. So again, even though we're finding more cases, the proportion of cases is likely fairly close to what it was before we expanded the number of people being tested. That also seems to coincide well in the Vidant testing, which is system-wide, not just here in Pitt County. They're running about 5% positivity, a little bit of an uptick with this weekend's activity too, but probably not to 12% positivity, and also seems to coincide with the state number. So this first graph is our graph, looks very similar to the graph that the Vidant folks showed tonight. You can see there are some days where we've had no cases. We had the 2 big days over the weekend that accounted for our big jump in case numbers over the weekend. And then we were back down in that 2 to 3 case range again there. So there's probably a little bit of an increase in our average number of cases in the last few weeks here. But overall, if you take out the 2 high days, our range is still basically between 0 and 13 or 14 cases a day. And most of the time we're in the single digits in the cases that come in. So we tend to be, I think, at a slow, steady burn in terms of the number of cases and how they present, which is really what we wanted. I'm going to hit the next one, Betsy.
Yes.
This is the cumulative case count for the county. Again, you can see there's been a bump up over the weekend. Again, the cumulative case count will always go up because we don't remove cases from these numbers. So that curve is always going to trend up. What we'd like to see it do is obviously to slow the trend at the rate at which it's gone up. But it's never been a geometric increase, which is a good thing. The next case, don't believe we showed you this curve. Want to switch next curve, Betsy? Thank you. The next curve here shows our recovered rate. And so we started plotting recoveries. And as of yesterday, we estimated there were 265 recovered individuals in Pitt County from COVID-19. And then finally, the last chart kind of summarizes the data. The total testing, a little over 3,000, negative testing, 2,800 and change, positive tests at 403, the recovered at 265, and we are steady at 2 COVID-19 related deaths. which I think it's unfortunate those individuals died, but that number is much lower right now than I think any of us would have hoped for, and I believe that to be a good thing. You can take that slide down. The other thing from a data standpoint that I wanted to share with you, I'm going to go over the numbers with you. I did not have the slides pulled up tonight, are the racial and ethnic breakdown of our data. And this is consistent with what has been seen across the state. Earlier in the outbreak, I analyzed 84 cases. That was on April 17th. At that time, we found that 47.6% of cases were amongst African-American, non-Hispanic individuals. Black females accounted for 22 cases, or 26.2% at that time. Black males were 18 cases and accounted for 21.4% of individuals at that time. We had no one identified as Hispanic in that early data analysis. On May 29th, I reanalyzed data from our morning data run. With that time, we had a total of 279 cases. 154 cases were amongst African Americans, or 55.2% of the total cases. 95 Black female cases accounted for 34.1% of the total. 59 Black male cases accounted for 21.1% of total cases at that point in time. African Americans represent about 31% of the population in Pitt County, so a clear excess of cases amongst African Americans. At this point, we did have individuals identifying as white and Hispanic in the data set. 38 cases, or 13.6% of the total cases, were amongst Hispanic, white Hispanic individuals. 25 female cases accounted for 9% of the total cases. 13 male cases accounted for 4.6% of the total cases. White, non-Hispanic, and unknown accounted for 31.2% of total cases. So I just wanted to review that with you. I presented that data to the Pitt County Board of Commissioners last Monday in my COVID-19 report to them. Felt it was appropriate to share with you all tonight. Our clinical services, again, I'm happy to report that all of our clinical services are operational at this time. Where able, we continue to deliver services via telehealth or in a blended telehealth / in-person visit, where we bring that individual in only for the things that we actually need hands-on with that individual. I'm hopeful that going forward, we'll be able to do this in the post-COVID-19 world. I think it will help us improve service delivery. We know that transportation and childcare challenges often keep patients out of our clinic. And if we can do some of the history taking and education through a virtual platform and have the patient in the clinic just for what we need hands-on for, we can decrease the amount of time they need to spend with us and hopefully improve their attendance at clinic visits and their satisfaction with clinic visits. Nutrition and WIC. During COVID-19, the state has begun direct issuance of WIC benefits. This has helped our WIC numbers dramatically. Our caseload is up. As of May, the end of May, we were 114% of required baseline, so we were over baseline at the end of May. Our June numbers to date also look very good. We're already at 86% of our required baseline on June 9th. All of the WIC flexibilities that I've previously mentioned remain in place at this time. Our health education division, in spite of COVID-19, work continues to go on with our tobacco and e-cigarette control programs. That's a regional grant that Pitt County Health Department administers. We continue to work on those as a health priority. We also have a regional prep grant for pre-exposure prophylaxis, and work on that grant goes on. We have hired a new coordinator for that grant, and she has dove in and taken the ball and run with it. Childbirth classes remain suspended at this time due to COVID-19. And our health education staff are working the hotlines. They are also working in their base programs, but we are using them to staff our hotlines. And that's worked well for them and for us. Marcia hit all of our Financial Act things. One thing I will mention under finance, we will be receiving some of the CARES money, which is a federal grant to help local counties with local expenses. And that money will be used to fund a testing program here in Pitt County. There's a number of balls in the air on that yet. Number one, we're waiting for approval from the county manager to schedule and begin operating those clinics because that funding actually has to arrive to the county before we can do that. We're looking at lab vendors, as you heard earlier, and where we can get that done at the best price. The plan is to stand up 2 testing sites within the city of Greenville, one at Greenville Housing Authority and one at the Moywood neighborhood. Those are communities of color, and there's been an emphasis to test more in communities of color. So we wanted to do that. We will have a 3rd roving testing operation, which will spend a day in Farmville, a day in Bethel, a day in Grimesland, and a day down in the Aden-Grifton area, and rotate between those sites during the week, spending a day at each of those sites. On Tuesday evenings, we will have after-hours testing available at Pitt County Health Department. That's our normal late night clinic. And we felt it would be a good idea to offer some testing after normal work hours were over for people who might not be able to get to testing sites during the daytime. So we will have that available during Tuesday evening clinic hours. As mentioned earlier, in environmental health, our division director position is open due to retirement. That job posting closes this Friday, and we are hopeful that we will have some candidates. As of the moment, I am doubling as the division director for environmental health, as well as my normal duties. Most of the inspections are on modified schedules per the North Carolina Department of Health and Human Services, again, due to COVID-19. Let's see, we've hit the July meeting, so that's done. Evaluation, a couple of my notes, I'm just talking to myself. It's been a long day. Reopening guidance. In your packets, I've included a draft of my reopening guidance for Pitt County. This guidance makes operational and hygiene recommendations for businesses based on the type of business. I stress this document has not been reviewed by our Pitt County food and lodging staff, nor has it been reviewed by the county attorney as of this evening. It is not keyed to case volume or the governor's phases. It is intended to serve as a guide to living with COVID-19 while allowing the freedom to return to previous activities. And that ends my report. I'm happy to answer questions about that reopening guidance if the board members have questions.
Well, thank you very much. You did a lot of work on this. We appreciate it. And see Dr. Hayes and Lowell Spade have some questions for us.
Dr. Silvernail, I heard the CDC had changed some of its thoughts on whether the virus is easily transmitted by non-symptomatic individuals. I don't know if that's correct, but that's what I heard, as well as whether they have changed their guidance on how the virus persists in the environment. Are you familiar with any new updates from the CDC?
Sure. The environmental persistence of the virus is probably far less than originally thought. And some of the heavy duty cleaning activities that were recommended earlier have been reduced. Most normal cleaning will destroy this virus, and it is not felt to be as environmentally persistent as once thought. So that's a change that's come out in recent days in the news and from the CDC. The issue of asymptomatic carriers and transmission, this has been back and forth. I heard the same story, I'm sure you did, in the news yesterday. The World Health Organization says that asymptomatic transmission is rare now, or at least one of their folks is quoted as saying that. I certainly believe that asymptomatic individuals are less efficient at spreading the virus, but I do believe that it's possible for them to spread the virus. The CDC recently expanded the contact tracing timeframe for contacts of asymptomatic cases. And with a symptomatic case, we look back 2 days prior to onset of symptoms. In an asymptomatic individual, we are now instructed to look back 10 days, which again, from a contact tracing standpoint, gets a little tough. If I were to ask almost anybody in the room, who were you within 6 feet of 10 days ago? I'm not sure most of us could remember that. Now at the health department, we're all sort of in the same bubble, so we might be able to give you an answer. But I think in the general public, that's a hard question to answer. So we do from a contact tracing standpoint, struggle a little bit with that. But there's certainly some controversy there. I do believe that asymptomatic individuals are less efficient at spreading, but I think they can spread. I think the degree that they can spread is still somewhat debated. Did that get your question, Dr. Hayes?
Looks like Kelly
Yes,
Pack
thank you.
Smith and Tina Dixon have questions, so. And Lowell, so Kelly first, I guess Kelly, Tina, and Lowell.
Okay, just really quickly, Dr. Silvano, if you'll think back to your report really quickly, you said you were quoting some numbers about how our communities of color were disproportionately affected by COVID. Do you have any speculation as to the reasons why? Are we talking just a matter of comorbids, or is there something else that you've heard that might be the reason and the cause?
Well, the analysis doesn't include severity, Kelly.
Okay.
Simply distribution of cases at this point. I think some of that is based on living in more communal settings, apartment complexes, closer spaced neighborhoods. I think that has a lot to do with it in terms of the spread of the virus amongst individuals in an apartment building or other areas where the housing is closer. Think of urban versus suburban. I live out in the country. My nearest neighbor is probably, well, a few hundred yards across the driveway from me. So in a city, your next door neighbor maybe feet away from you, and people pass much closer. I think that has a large part to do with it. I don't know that the virus, that Black individuals or African American individuals are more susceptible to the virus. I think it probably has to do more with the communities in which they live and the population density at which African Americans live in an urban environment.
Thank you.
Does that answer your question, Kelly?
It does. It does. I'll be very interested to see how research moves forward in that area and see what comes out of further data analysis. But thank you. Yes, it answers my question for now.
Looks like Tina Dixon's next. Tina's got a new hairstyle, looks like.
Yes. I was wondering if the roving unit would also be going to Bethel, because you mentioned the other townships within the county, but Bethel, I don't remember hearing that.
Oh, I'm sorry if I left that out. Yeah, if you think about Pitt County as roughly diamond shape, our plan is to hit the periphery with that mobile unit. So Farmville, Bethel in the north, Grimesland in the east, and then somewhere down in the Aden-Grifton area, so that we hit the southern point of the diamond. So yes, Bethel is one of the targets.
Right. Thank you.
For that. You're welcome.
Lowell Spades next. Lowell, you're up. There he is.
If I hit that unmute button, it works a whole lot better. Sorry. Okay, let me try that again. That was a great question. I hope this one's as good. In the reopening guidance for Pitt County, do we need to reference what to use when we clean, or how to clean, or reference the CDC guidelines for how to sanitize, as opposed to just saying sanitize?
We can. There is existing guidance out there from CDC and EPA on how to cleanse and what to cleanse with, Lowell. So that certainly can be placed in there. This is a first draft, and certainly there's room to expand upon this. The last month has been much busier than I expected. Again, that Hydra concept. And this was also a little bit more tedious in terms of thinking through this and trying to make something that's easy to read and follow, and not overly complex for people if this ever were to be implemented. And going forward can be added to our preparedness plans. So if, God forbid, we ever do have to go through some sort of a shutdown again, We have some guidance as to how to reopen on the other side of it. I think that's a failing in our preparedness plans, not only here in Pitt County, but nationally, that we've talked about social distancing, lockdowns, shutdowns, these sorts of things for years as a way to stop a novel virus or impede the spread of a novel virus. But nobody's ever really considered how to reopen after that. So I think that's partly why we struggle with this so much now. But yes, we can add hyperlinks to that guidance into the document. I wanted to have something ready for y'all and complete that assignment, or at least have a start on that assignment for you tonight. Again, I'm a sworn officer of local government. I have to follow the governor's order as it stands now, so I'm not asking for permission to violate the governor's office order, and don't plan to violate the governor's order, but I did want to prepare some guidance for us as a community as directed.
No, I appreciate it. It's good. I thought it was easy to use. I mean, I wanted to see the little areas I was interested in and read them. I liked it a lot.
All right, Rex. I see Rex Fleming has a question.
Yes, I heard them talk about the remote testing. When will that start?
We're waiting for the CARES Act funding, Rex. Once the county has that, the manager will give us a period when we can start to spend that money, and then we will get those testing sites stood up. There's a couple of wild cards in there. There's the potential for HUD to want to place a freestanding testing site at Greenville Housing Authority. That may allow us to redistribute our assets. I have a phone meeting tomorrow with the Old North State Medical Society and the Andrew Best Medical Society here in Pitt County to talk about testing with them. They're interested in doing some testing here in the Pitt County, or assisting with testing here in Pitt County. So there's another wild card that again may allow us to redistribute some of those resources. So this is it's a rapidly evolving situation, I guess is the buzz term for COVID. But part of it is, once I have the financial okay from the county manager, we will move forward with those plans to stand up the testing sites.
Okay, Martha Engelke has a question.
Yes, Dr. Stephanie, I wanted to get your thoughts about the report that we heard earlier, where, if I understood what Mr. Floyd was saying, is that the hospital had a recommendation for universal masking that they were going to bring forward. Could you comment on that?
Dr. Waldron did speak to the Board of Commissioners last week about masking and encouraged masking. Last Monday seemed so far away. There's growing evidence that masking in public gatherings can decrease the spread of COVID from person to person. I think the issue with it is the enforcement. So we certainly, in our messaging, have included the wear, wait, and wash messaging. If you see, I have a mask around my neck tonight. Dr. Ramsey came in; he has his mask with him. Mine is color coordinated with my shirt. He's got a lovely Carolina blue mask over there. So there is growing evidence that it is effective in decreasing the transmission in settings where people can't maintain social distancing. I'm not sure that there's a public appetite for it, and then that's something we need to change the hearts and minds of folks to do that. When I was out and about this weekend, I saw some folks wearing masks in public and some folks not, and I agree that it's probably beneficial. I'm not sure there's a public appetite to be forced to do it.
Thank you.
I guess one question is whether there should be anything in here. I may have missed it about masking. We've got the 6-foot rule, which is absolutely recommended. That Dr. Mandy Cohen talked about. So it's something to think about. Now you have to actually run this by you mentioned a couple groups.
Yeah, I'd like to run this through my food and lodging folks, have them look through that, see if they want to add anything. I want to run it through the county attorney. And when you read this, you can see that there's a statement in there that all usual and customary hygiene rules and regulations apply. We didn't want this to become a substitute for the sanitary code. We wanted this to be applied in addition to the standing sanitary code that covers occupancies and businesses. So that language is in there. Going back to the mask for a minute, there's been a question, well, can you as the health director order masks for the community? In talking with the county attorney, the county attorney's opinion is that no, the health director cannot order that as a countermeasure to this virus. The Board of Health could consider adopting a rule for the county. Again, the enforcement of that would fall to local law enforcement. The other option would be the commissioners under their emergency declaration power could potentially adopt a resolution requiring masking in the county, but that resolution would only apply in the unincorporated parts of the county. So it's not as simple and straightforward from a legal standpoint.
Okay, Dr. Harrell.
This question is likely for Dr. Silvernail and Dr. Ramsey both. Based on the earlier presentation we had from Vidant, it seemed over the past couple days or the past 3 or 4 days that we've had that large uptick in positive cases, the 50 or so that it was over the weekend. But from what I understand correctly is that many of those, or at least a certain number, were asymptomatic. Early on, over the first couple months of this, we were only testing symptomatic patients, if I remember correctly. So do we expect that if we were always testing everyone, even asymptomatic patients, that the numbers might be similar?
They may be similar or they may be a little higher. We have done some asymptomatic testing of our staff at the hospital in cases where there may have been exposure at home or elsewhere, and but our percentage of positives, and also with some of our pre-surgical testing, it's only been about 1% positive. And these were all truly asymptomatic. So it's hard. It's a good question, Dr. Harrell. It's hard to say. Any thoughts, Dr. Silvernail?
Yeah. It also appears, Dr. Harrell, that some people are more efficient than others at spreading. I won't say that everybody's a super spreader or that there always needs to be a super spreader. Folks who are very, very efficient at spreading the infection. But as we've looked at some family groups, we found some family groups where if one person is positive, the rest of the family also tests positive. And then we've had a number of family groups where if there's one person positive, nobody else is positive. And some family groups where there's in between, where there's an index case, and then there may be 1 or 2 other family members are positive, but not everybody. So it does appear there's probably some difference in ability to spread the infection from infected individual to infected individual. And that some people are more efficient at spreading and some folks are less efficient at spreading it, even in family groups.
Okay, any other questions for Dr. Silvernail? So it sounds like maybe in summary, perhaps put some hyperlinks in and then any other editing and move it on to some further review before it comes back to us. Okay.
Yes, sir.
All right. Are there any other items to consider for tonight's meeting? Hearing none, is there a motion for adjournment? I think looks like Dr. Hayes and Kelly and Dr. Harrell. Okay, is there a second?
Second.
Second. All right, very good. Any further discussion? We'll have a roll call vote for yeas and nays.
Tom Colson,
Yay.
Tina Dixon,
Yay. I couldn't unmute my phone, my computer. It just wouldn't let me.
Martha Eaglekey,
Yay.
Rex Fleming,
Yay.
Adam Harrell,
Yay.
Scott McIntosh,
Yay.
Lowell Spate.
Yay.
All right, motion, it's unanimous, meeting adjourned. Thank you.
Thank you.